Thank you so much, Dr. Lalit Mohan sir, for those kind words of introduction. So, yeah, at Mahatma Gandhi, as you see down there, we have started a program in collaboration, and Mahatma Gandhi seems to have got many firsts now in liver transplant field of liver transplant. So, let me thank Dr. Jasuja and his whole team for inviting us and sharing our thoughts on HCC. One of the major disclaimer I would like to point out here is I'm a surgeon and I'm sitting in midst of all the medical oncologists. So who are usually, apart from the NDT, they are usually at loggerheads. Am I right, ma'am? So there we get a good smile. So when we look at HCC, it's a rising cases in worldwide, and when we look at the figures which WHO has predicted, there is going to be a significant rise in the unresectable cancers, which specifically liver cancers. It has slowly risen from the sixth most cancer to the fourth most common cancer, leading to death. And by 2040, about 1.5 million population would be infected with HCC. Now, why we are talking about this is many a times when the patient presents to us in our outpatient clinic, they seem to have got an advanced disease. There is an MDT, the physician sees or a surgeon sees, they do discuss with each other. But many a times we find that these patients have practically become unresectable in terms of not being able to give them the standard of care, which is surgery. So even BCLC, which has accepted this classification, they have now revised their BCLC in 2022 and have accepted that in advanced stages there are newer treatments available. Previously, these patients were usually condemned, but now with the advent of many novel agents and targeted therapies, this has been incorporated and revised. So what are the management options we have? Apart from the systemic chemotherapy, we have had targeted molecular therapies, immune checkpoint inhibitors, combination therapies, and the future prospects of novel drug therapies. So if you look at the timeline, sorafenib now, even before we started our practice and when sorafenib actually came into the practice, we were all gung-ho about, wow, sorafenib is the miracle drug, but now that seems absolute history. And over the last 2 decades, a lot of changes have happened. So sorafenib, the only reason why we are still quoting sorafenib is everything is now compared with sorafenib. All the trials are compared with sorafenib, and the newer drugs are all coming up, and we'll start talking about all these. Just to put up the slide about SHARP trial, we all know, and that becomes the basic bottom line where we compare. So coming to the next drug after sorafenib, after a long time, we found lenvatinib. Again, there were various trials done which showed that lenvatinib was not inferior or non-inferiority in comparison to sorafenib. And now I think rarely anybody uses sorafenib in their practice and have now moved on to using lenvatinib. And that was the REFLECT trial, which showed that the progression-free survival time to progression and objective response rate were much higher as compared to sorafenib alone. And hence now lenvatinib is the first line therapy. We'll now look at the other targeted molecular therapies as well. Regorafenib, again, it's an oral inhibitor of VEGFR1, 3 and the other markers. It was initially approved as a second line therapy way back in 2017. Again, this was compared with placebo, which showed an overall survival of 10.6 months compared with 7.8 months, a higher median progression-free survival and a higher time to progression with a higher rate of objective response rate. But the only point to be seen in the resource trial was that this drug, regorafenib, was used in those patients who progressed after using sorafenib. So they were not naive patients. So that's one of the major point to be noted in this trial. Coming to the next was cabozantinib. Again, this is a small molecule of TKI, where in the Celestial trial, it showed an improved median overall survival of 10 months as compared to only in 8 months, with a higher progression, improved progression-free survival, with a higher objective response rate to RECIST, and this was significant statistically, and hence in 2019 this drug was approved by the FDA. Here the difference was this patients was approved again. I mean, this drug was approved again for all those patients who had previously received sorafenib treatment. Coming to the next targeted molecular therapy is ramucirumab. Again, this is a human recombinant IgIg1 monoclonal antibody. Here also it showed a great difference with increased progression-free survival, increased time to radiographic progression, and increased disease race control. The REACH2 trial, this was the subgroup of the trial of the REACH trial, where they looked at those patients who had an alpha fetoprotein of more than 400 and divided those patients who had alpha fetoprotein of less than 400. So in those patients who had less than alpha fetoprotein of less than 400 did not show a significant increase in this PFS or the disease control rate. But those patients who had a higher alpha fetoprotein rate had a better overall survival, and hence it came in as an approved as a second line of treatment, specifically in those patients who had alpha fetoprotein of more than 400. Coming to the immune checkpoint inhibitors, that is nivolumab. This drug has been very often spoken about in many other GI cancers as well. But even in HCC, there was a checkmate trial which showed that the overall objective response rate was 20%, with 39 partial responses and 3 complete responses in this trial, as you compare it with sorafenib. Many of our, more than half of the patients had got a good control of the disease, and the disease stabilized at least up to the first 6 months period, and hence it was again approved by the US FDA way back in 2017. Here also, those patients who were treated first with sorafenib can be given nivolumab. Coming to the next ICI, it is pembrolizumab. Again, these are all tongue twisters, as my previous speaker has also spoken about. It's a monoclonal antibody, PD-1, which again was included in a Keynote 224 trial, where it was looked at the objective response rate and the median time to progression with the progression-free survival. Both was higher, including a higher median overall survival rate. With here as well, there was more than half of the patients had responded, disease was under control, and the stability of disease was observed for almost up to a period of 1 year. Now here, that is why this drug was approved as again a second line therapy after the Keynote 224 trial. Coming to a major combination therapy, etolizumab and bevacizumab. Bevacizumab has been used in the past in many other GI cancers. We know how these two act. It's a monoclonal antibody which binds to PD-L1, and bevacizumab is a humanized anti-VEGF monoclonal antibody. Both these were used in combination, and it was found that the overall survival was much higher if they were used in combination than as compared to using sorafenib alone. And this combination actually gave the highest overall survival. Specifically, the point to be noted here is, because of this long survival, now this combination therapy has been approved as the first line treatment as a standard of care in those patients who present to you with unresectable HCC. The other combination therapies are nivolumab plus ipilimumab. Again, how does ipilimumab act? It blocks the CTLA4 pathways and thereby increases the activation and proliferation of the T cells, leading to infiltration by CD8 and T cells, which will probably destroy the tumor. Nivolumab, again, we know it blocks the PD-1 and PD-L1 pathways, thereby again killing the capacity of cytotoxic T lymphocytes. Given the high expression of both these on the T cells, the combination therapy is likely to reduce the immunosuppressive microenvironment of the tumor, and hence the Checkmate 4.0 trial again showed a higher median overall survival with a higher objective response rate and a disease control seen in more than half of the patients. The median duration of the response was about 1.5 years, which was significantly higher, and hence this drug combination has been kept as a reserve for second line treatment, and because it has continued to show clinical responses as well as long-term survival. So these are just a schematic diagram of how the combination therapy will act. So these are the various combination therapies at various point, and PD-1, CTLA4, VEGF, and how they would be acting at various levels, and how do we try and achieve a response in unresectable HCCs. Coming to the specific therapies, VEGFR targeted therapy, tivozanib, again, relatively a newer drug, which has a lesser effect on tyrosine kinase inhibitors and has got dose-dependent activity against HCC in vivo. It has got a better tumor efficacy. Again, the comparison comes to sorafenib. And in first line, donafinib, which was now seen as it's used in a trial where it has given a significant overall survival more as compared to sorafenib. The another drug is apatinib, is used in as a second line therapy. It is in phase 3 study, A-HELP. That's a study which is being done, and it is given a significantly overall higher survival rate as well as a higher progression-free survival rate than as compared to placebo. The c-Met targeted therapies, it's a receptor TKI for hepatocyte growth factor, and it is found in approximately half of the patients who present to you with HCC. Hence, the selective, if you use tepotinib and quematinib, both and non-selective c-Met inhibitors, they can be used in different trials with potential use in the HCC, either as a first line or second line therapy. And they seem to be very promising, but in the early phases of trial, the reason why there is an interest in these drugs is because they seem to have less drug toxicity which they produce. Coming to the TFG beta targeted therapy, again, galunicitrab and TGF. It's a TGF beta receptor inhibitor that has been studied as a monotherapy and in combination with sorafenib, phase 1 and phase 2 trial. Both have, it has been seen that the TGF beta pathway has dual anti and pro-tumoral activities in cancer cell, and in the early phases it may be beneficial to arrest the cell cycle and can lead to apoptosis, and in advanced stages it can promote tumor progression and metastasis by enhancing cell motility. So if it is used in the early stages, it may have some beneficial effect. Coming to endoglin targeted therapies, endoglin CD105, again, it's a type 1 intact transmembrane glycoprotein, which is a co-receptor of TGF beta ligands and plays an important role in fibrogenesis and angiogenesis. So there are various trials. Again, caratociximab is an anti-endoglin antibody which did not show adequate efficacy in the phase 2 trial, even those patients, after those patients who had received sorafenib. So in 2019, again, ESCO reported this trial in combination with sorafenib did show objective response rate 21% as per the RECIST criteria, and the median overall survival again was higher at 15 months with a higher median time to progression of about 4 months. Coming to the other targeted therapies, there are various other in the various phases of trial. Phase 1 trial, we have got fisogatinib, which has produced a good clinical re-response rate in specific patients with advanced HCC with a good objective response rate of 17%. And again, in these patients, the trial validates the effectiveness of blocking the FGF19 and FGFR4 axis, and that is how the biomarker potential is seen in these HCC patients. The colony stimulating factor CSF1, again, is a cytokine mainly produced by tumor cells that recruits macrophages under pathological condition. When this is activated, it leads to tumor-associated macrophages which secrete growth factors and contribute to the tumor growth or metastasis. So here, again, if we use a CSF1R inhibitor, one of the drugs used is pexidartinib. It exhibited anti-tumor activity in xenograft as well as allograft HCC model. Again, these therapies are under trial and being studied. The other PD-1 and PD-L1 inhibitors, immune checkpoints, we all know tislelizumab versus sorafenib as a first-line therapy in the rational trial has been used, and pembrolizumab has been used and has been now approved as a second-line therapy. The other notable drug, which is durvalumab and evolumab, both are again under trial. There are various studies which show that the overall survival is higher with an objective response rate of 14.7% with pembrolizumab. So these are again in the various phases of trial, the phase 1 and phase 2 trial points. And the other immune therapies which are now being still further investigated are lymphocyte activation gene 3, T-cell immunoglobulin mucin, T-cell immunoglobulin and ITM domain, and adenosine A2 alpha receptors. So what these Zhao et al. And the group found that PD-L1 inhibitor in combination with TIM3 and LAG or CTLA4 inhibitor, they would result in revitalization of tumor in vitro infiltrative lymphocytic responses in most of the patients, and further enhance the effect compared to PD-L1 monotherapy. So there are various things which are again now being studied, and there are newer therapies which are under investigations. But the combination therapy has already caught eye. There are various combination therapies now being used. Regorafenib and pembrolizumab are the first line therapy being studied, again still in a phase 2b trial, is a multi-center trial. Lenvatinib and pembrolizumab have got a promising anti-tumorigenic activity and are being studied again in phase 1 trial in Keynote. There are many multiple active trials which are combining cabozantinib and nivolumab or atezolizumab, and these in combination can be eventually used once we get the results of this trial. The off-note, the Himalaya trial, which is again a major trial being done, where whether we can use this as a first line therapy, where you use durvalumab with tremelimumab, it was being investigated whether we can use, and it was presented in the ASCO virtual scientific program, where it showed the overall response rate was much higher in those patients where we used T plus D, that is tremelimumab with durvalumab, and the overall survival rate was much higher. They are in still phase 2, phase 3 trials, and eventually we may switch over to this Himalaya trial combination as the first line therapy. The future prospects, again, there are various antibody drug conjugates, glypican GPC3, epithelial cell adhesion molecules, NYASO1, tumor endothelial markers, AFPs, there are Claudins 6, MAGE-A, and these are all being under investigation before we actually move on to any phase trials and comment upon either of these. So just the final slides. As of now, with all the meta-analysis which have been published, atezolizumab and bevacizumab are accepted and have shown superior outcome in the first line settings when compared to sorafenib and lenvatinib and nivolumab. The other first line therapy of this atezolizumab and bevacizumab has got a highest overall survival benefit as compared to lenvatinib. In second line therapies, we look at cabozantinib which has got a greatest progression-free survival and objective response rate. In second line, we can also look at regorafenib and cabozantinib as a combination drug because it shows a higher progression-free survival. So the ones in the red are the second line therapy on the first line, and the ones below are actually the ones below are still under investigations. So we are looking at these. These are the graphs which are still, again, the combination being studied as the first line. This has already been approved. This is the Himalaya trial, durvalumab with tremelimumab, and there are others which are being now investigated as a first line. So the jury is still out, and once we get that, till that time, we can follow this algorithm which I just mentioned in my summary slides. So thank you very much, and I'll be happy to take any questions.
Thank you so much, sir.
Using all these TKIs or immunotherapy and the patient responds and the tumor shrinks, does it make it resectable for you? Will you resect the patient?
So again, the bottom line is surgery is still the mainstay of the therapy. If you are able to achieve an R0 resection, again, that's what I said. This is the point for MDT discussion, and that is why an oncologist and an HPB surgeon should be part of the MDT. So once it regresses, and if I'm going to get, previously long back, we used to say that we need a resection margin of 1 centimeter, which eventually came down to 1 millimeter. So now any margin is generally accepted, because when we use the transaction modules like QSA, there is still a 0.5 millimeter liver parenchyma which is sucked into that QSA machine. So if you are able to achieve an R0 resection, so the answer to the question is yes. If you think that unresectable tumor has come down and can be resected, yes, you should go ahead. You should give them either surgical resections, or if they are fit for liver transplant, then they should be given liver transplant, because your disease has been stable. It has responded to chemo. That itself shows the biology of your tumor. There is a good chance if there is no extra hepatic spread, then these patients should be subjected to a surgical therapy, either resection or transplant, whatever is suitable at that point.
Okay. Thank you very much.
Welcome. Hi, ma'am.
Very nice talk. So I have two questions for you, sir.
Please.
So if it is a locally advanced tumor and you make it amenable for resection at any time point, do you use any time the consolidation therapy after the transplant, and what exactly it is?
Here still none of these therapies are actually studied in the adjuvant setting. So what we are asking is adjuvant setting, whether the role of systemic chemo or targeted therapy, is there any major role in adjuvant setting? So unfortunately, we don't have such a major role which has been studied. But off the cuff, yes, we do have patients whom we have transplanted. They do come back with to us with recurrent HCC. And when there is a recurrence, there are multi-modalities which you can approach. One of them is systemic chemo. But apart from that, there are various other modalities available like microwave ablation or TACE. And we have got some of our patients who have done pretty well with these TACE or microwave ablation. Now, in suppose some patients you think that TACE is not suitable or if it's a large tumor, then again the chemo is not going to work. If the patient in terms of cost wise is also difficult, TACE would be cheaper than using the newer combination therapy, then these patients would eventually go on to lenvatinib. Yes, so then you put these patients only on plain lenvatinib. But other combination therapies unfortunately haven't been studied, neither do we use in adjuvant setting.
Right. So this was the second question actually. Do you see any time use of immune checkpoint inhibitor in post-transplant recurrent HCC? So graft survival is something which is a question.
Yes.
So at what level of immunosuppression do you see that we can use? Say it is a minimal thing, and with say 5 or 10 milligram of Visolon, we can introduce that immune checkpoint. Do you still?
Correct. So the very fantastic question, and this absolutely clinically oriented, because we do get some of our patients in transplant OPD, post-transplant. So most of these patients, it's a very interesting thing to note that when they do have a recurrence of HCC, what we find is the liver function is usually very, very stable, very, very stable. And they don't seem to require a higher dose of any of the immunosuppression therapy. And Visolon is something which usually we use only for the first 1 month, and then we generally wean them off. So Visolon doesn't continue for a longer period. The time period of presentation of recurrence of HCC post-transplant is the earliest we have seen is about 3 months post-transplant, but we do get some who come back to us after a year or 2 years down the line. So none of these patients are usually on Visolon. So what we do is we reduce the tacrolimus. Most of these patients are on tacrolimus. So we try to reduce the dose of tacrolimus, and you can still continue MMF, which itself has got anti-tumorigenic activity. You can modulate the dose of MMF, and you can introduce one of the ICIs. But again, as I said, we really need, these are all one-off cases where we do use it, and I'm sure you also would have used it in your clinical practice, but we really don't have any real trial or any guidelines which would support that. So this would be practically absolutely individual comment, I would say. So we do use that.
Right.
And we do have some of our patients who don't need Visolon, who is on a 0.5 milligram of tacrolimus OD. And that also I'm little skeptical to withdraw, because I don't know if I withdraw, he may just suddenly go into rejection. So they have been stable for years and years.
Right. And the patients who are really on ICI post-transplant, have you seen any graft rejection risk which has increased because of that ICI?
So we haven't seen that as yet. Correct.
Thank you.
But again, time will tell us over a period how these patients would respond.
Thank you, sir.
Dr. Mehta, which are the patients with that medical oncology?
Sir.
We used to HCC whenever we are scared that Prof does not relate mental water. Which are the people sort of consult a transplant surgeon like you for the.
So again, very nice question, sir. And from the practical point of view, so all those patients who have got HCC, so there are various criteria for transplantation, and these criteria again are pretty old and are now being changed. So the oldest criteria which had got a fantastic success rate was the Milan criteria, which is again now revised. Then there is a UCSF criteria. So this also says that the tumor largest of 6.5 centimeter. Again, all these what I'm talking about do not have extra hepatic metastasis. So if they are confined only to liver, then they can be transplanted. Then we have got something called as up to 7 criteria, where if the tumor centimeter size goes up to 7, or there are 7 small tumors, you can still go ahead with no extra hepatic mat. You can still go ahead. So that's a Toronto criteria. Then there is a metro ticket criteria, where the longer you want to go, the larger burden of the tumor you want to treat, there is a higher risk. So the metro ticket idea is that the longer you have to travel in a metro, the higher cost you pay. So that is where, as the team, we need to sit and decide. So what happens is, many a times when we find, again, biology is the king, we all know that, and sometimes we treat, if you think that the tumor is pretty large, they don't fit into any of these criteria which are already published, then we can subject them to TACE or a microwave ablation or a radio frequency ablation, and see the biology of the tumor for the next month and a half. If there is no extra hepatic metastasis, then these patients would be ideally suitable to be subjected for liver transplant. And during the waiting period, if they have progressed, then that's a self-selection criteria. They have progressed on the your waiting period of 1 month, month and a half, and then they would obviously drop out from that. So those patients who do not have extra hepatic metastasis, have got a tumor size of up to 6.5 in the UCSF criteria, still have got about 65-70% 5-year survival, which in all criteria is pretty good, because any of these other whatever therapies we are talking about, none of these is able to achieve that kind of survival.
Yes, sir. They are very much for the hepatic transplant, but sir, they are in the classification BCLC. If it is category C or D, as we discuss all that things, ICI and then hepatic transplant, then it is more recurrence rates are more in the category A or B in comparison of the C and D.
So again, what BCLC, unfortunately, there are some criteria with BCLC. If you say a child PUC C, they technically child PUC C, they have actually just said that they are technically condemned. And we do have patients whom they do have a child C, CTP, have a tumor, and we still transplanted them. So that's one of the major fallacies still, which has not been addressed by BCLC, even in the revised guidelines.
Yes.
So we would still go ahead and do a transplant if, because what will happen is, child C, there is hardly any survival. If you look at the overall survival, forget about the HCC part. If there is no extra hepatic mats, only then they would be considered. But when you look at only child C, the survival is less than 3 months in these patients. So these patients will definitely benefit, have a higher outcome, because none of these child C would be suitable. Whatever chemo, IGI, whatever ICI we have been talking about, they are all for the early stages. They are all stage A with a good performance PSO1. There's a good performance status. These patients, if they don't have extra hepatic metastasis, ideally they are a superb and a fantastic candidate for transplantation, because if you look at the survival, all these trials, what I've gone through and studied, and even if you get 18 months of median survival, we are talking about 18 months and 2 years median survival. Whereas in transplant, we are talking about survival of 5-year time, which is 60 to 70%. So you look at the difference which you are comparing. So as a clinician, what I would want my oncology colleagues to understand is that yes, these therapies are definitely useful, but that doesn't mean that these therapies are the only things which will give you a good outcome. And that is probably one of the reasons why Dr. Sandeep wanted a surgeon to take this talk. And
yes, sir, that is the main thing, sir.
Absolutely. So if you compare it with liver transplantation, the success rate is much higher. So what we are talking about, again, we need to understand is these patients are unresectable HCCs. So these patients, even in liver transplant, if they have got extra hepatic metastasis, they do not come to a liver transplant surgeon. So in unresectable also, you can define, which has not been defined in the literature. In unresectable, when they say unresectable, they talk only about surgical resection, but they don't talk about liver transplant. So even there is a multifocal HCC, which is technically unresectable tumor, which means we cannot do a liver resection on it, but we can still go ahead with transplantation in these patients. If, again, the bottom line is, which Dr. Mohan sir had asked, the bottom line is, if they don't have extra hepatic metastasis, these are the patients, at least they need to be told about, because transplant has actually now become a standard of care with a good outcome. So I was asking me what is the success rate, at Dr. Sandeep was asking success rate post-transplant. So we usually have about 90% success rate. Most of our HCC patients have got good performance status, and they actually undergo transplant not for their child's status, that is B or C, but and so that their liver disease is not decompensated. So they are very well compensated patients, so they can technically withstand a supramajor operation like liver transplantation. Have I answered your query?
Yes, sir.
One question from my side here.
Please.
Coming to this resection part of it and the neoadjuvant and adjuvant part of it,
Yes.
there is a lot of discussion and a lot of theory which is definitely attached to it. But in the clinical practice, that really doesn't happen, unfortunately. So if you really ask us, our experiences, I'm from Hyderabad, we have a good liver transplant team. But getting a stage to the level of getting resection is almost, we rarely see. Maybe, but liver transplant always remains a fallback upon these patients. Just a couple of words from myself.
So yeah, first point, I completely agree with you, because as we already discussed, what you see in your clinical practice is way different. When we talk about theory, yes, it is different. What you are talking about is probably liver resection and salvage transplant. So in those patients, again, salvage transplant is still a better option. What do we mean by salvage transplant? Is that what you're asking, sir?
No, I didn't ask for the salvage transplant. I discussed about, of course, only resection part of it. Because there are patients who might get some kind of bridging therapy for transplant. That's a different story altogether, which is usually done by TACE and etc.
Correct.
So, but a patient who has kind of a disease and one wants to wait for an eventual resection, and with the help of TKIs and other medications, that usually doesn't happen in the clinical practice.
No. So it does not. Yes. So very nice. So what you're saying is there's a neoadjuvant type of a therapy where we want to look for resection, wait for resection. There is no such role of using any of these agents and then going ahead for resection. If you think that the patient is resectable, and again, there are a lot of criteria for liver resection, though since this topic did not involve it, I have not touched upon it, but the patient should not have child B or C cirrhosis, should be in early stages of child A cirrhosis. There should be a good remnant liver of more than 40%, and you should be able to do a good liver resection with R0 margin. So in these patients, why should you wait? What is the reason to wait? Why would you want to wait? You just go ahead and offer them resection, because again, as I said before, also reiterating that surgery still remains the mainstay of this liver cancer and probably any of the other cancer you have in your body. If the surgery is not possible for whatsoever reason, then that is the time we bring in the other modalities of treatment into play, right?